So for today's class, we already know the epidemiology, we know about the virus and how it works. So today it's a bit part of clinical diagnosis and treatment first, okay. Then we will look over the National AIDS Control Program NACO and the NACP latest. Previously it was 4 up to 4 you have to study. Now NACP V has been implemented from 2021. And I see in your PARC it has been also written in the latest edition of PARC, NACP V is discussed. So we will go to that. For diagnosis, we all know about what are the available serological tests. That one is ELISA. Other we can do. Which one? Western, East or Southern? Western. Okay. And what serological test? We also go by in the rapid test. Any idea from your micro knowledge? In the rapid kit, rapid test. That is rapid kit that you use in your ward or even emergency to rapidly diagnose whether the patient is HIV positive or not. What test principle it is used? Paper chromatography? Just only color? Or go through your book, micro again, just give a quick revision. And what are the antigen detection mode? That is P24 antigen capture test and PCR, that polymerase chain reaction test, okay. Absolute CD4 lymphocyte count, it is most widely used predictor of HIV progression. After we diagnose the patient that he is HIV positive or not, we have to also measure his CD4 cell count to see whether the treatment is responding or the HIV is progressing more towards, that is CD4 cell count. Absolute CD4 lymphocyte count, it is actually counted using a formula. The formula is not available in PARC, so I don't know whether you have already studied it in microbiology or not. And what is the risk of malignancy? It has been asked. When in which CD4 level? That CD4 level less than 200 cells per PL. What is P? Picoliter. This is the HIV testing algorithm that first, if we got a blood sample, then there will be first test. It might be a rapid test or ELISA. Now it might come as negative, might come as non-reactive and reactive. Non-reactive, we will diagnose them, okay. Negative. If it coming as reactive, then we go for a second test. Why we do the second test? That to decrease the false positive. Because the first test, if the first test, which part increases false positivity? More sensitivity or more specificity? Jore. False positives detection chance, false positive increase হওয়ার চান্স কখন বাড়ে? কোনো টেস্টের হাই সেন্সিটিভিটি থাকলে না হাই স্পেসিফিসিটি থাকলে? হাই সেন্সিটিভিটি থাকলে. That's why we introduced a second test which has high specificity. And when we introduced firstly highly sensitive test and then highly specific test, what about the net sensitivity? If we do it is not doing in parallel, it is sequential. So what then it might come as reactive or non-reactive. Sorry, the red block is not coming as good as I hope. So this red one is positive, and if it coming as non-reactive, then we call it as a discordant result. What first test was suggesting, second test is not. Then what we do? We introduce a almost close to a golden test that has high specificity. Okay. So gold standard test when we introduced, if it coming as non-reactive, we go by negative, or if then it is coming is positive, then we go by positive. Actually, what is the first test? We go for ELISA. এই সামনের লাইটগুলো অফ করা যাবে একটু হলেও ইয়ে হতো ফার্স্ট উই ইন্ট্রোডিউস ELISA. What is the second test? We introduce Western blot, and then we introduce antigen detection test. Obviously, if the antigen is here, antigen is have to be very specific. Then there must be HIV positive. Okay. And in reality, we also get this kind of thing, that is indeterminate. What we do in case of indeterminate, it has been asked, it is a very favorite question in Viva, that what to do? Repeat testing. Okay, this time we failed to detect. Now going by 3 months. Now coming to the control part. For control, we first have to think about the prevention. We all know who are the high risk group people, who are the breach population, and we are the general population. Who are the high risk groups? সবার আগে ওটাই মাথায় এলো। আর ট্রাক ড্রাইভার তো ব্রিজ পপুলেশন, IDU, দেন আগের দিন কিছু থেকে গেছিল হাইয়েস্ট চান্সেস অফ ট্রান্সমিশন কাদের মধ্যে হচ্ছে দেখতে পাওয়া যায়, ব্লাড। মানে বললাম প্রথমে ওটাই কমার্শিয়াল সেক্স ওয়ার্কারটাই মাথায় এলো। দ্যাট is how in our society also movie, web series all about, not focusing on you. Okay, so for high risk group, what we can do, we cannot steal their from profession or addiction or blood, or also blood transfusion is very necessary. So what we can do, we can go by education. What is the education type? Behavior change communication, BCC. Okay, what to do? We have integrated counseling service in the ICTC. What are the ICTC? What are the functions? We will come to it later. And also combination of HIV prevention, that promotion of both male and female condom, needle and syringe program, opioid substitution therapy. Needle and syringe program, it is actually targeting IDUs, that is intravenous drug users. Okay. What we do here, we actually provide them fresh needles. We counsel them, okay, please leave your addiction and that, but what we do, we provide them fresh needle. Okay, go and take another sort of heroin, possible. We cannot stop in medical profession, we cannot in the charge of stopping the production of heroin. Okay, so what we can do, we can make them use new needles, and also with them we can start on them opioid substitution therapy. What is the usually drug of choice? Methadone or buprenorphine. Also voluntary medical male circumcision. Okay, this circumcision is not the cause of phimosis, but to decrease the transmission of HIV, okay, from seminal fluids. And also prevention of blood-borne HIV transmission. All blood should be tested for HIV, both type 1 and 2, before transfusing to others. These are the three picture to please make it understand, if you can remember. Then coming to the second part, that is anti-retroviral treatment. For there, what we can do, we all know that in your pharmacology you have read various types of medications is available there. NNTI, RTI, NRTI, protease inhibitors, integrase inhibitors, entry inhibitors, and those types. Okay. This is a graphic diagram picture to understand. First, getting to the entry, we can use CCR5 antagonist. What are the entry inhibitors? Anybody remembers? Okay, come to it later. I will also gave a table. And then where we can, second part, where we can prevent or treat that fusion inhibitors. Third, reverse transcripted inhibitors, where we have two types, that's NRTI, NNRTI. Then here integrase strand inhibitors, that's integrase inhibitor that we know. Then coming to the protease inhibitor, when it is getting out from the cell, and also we can inhibit release and the maturation, because this kind of release and maturation inhibitor, this kind of drugs are still on experimental stage. So we have to remember up to protease. I have given this picture because it might come as a picture in your INICET and just one question mark. What drug is suitable here in the same diagram? Okay. So what are the entry inhibitors? Or enfuviratide and maraviroc. Maraviroc I expected from you. It has been asked. Okay. Try to remember. Then NRTI, what we most use, that tenofovir. And there are some specific about tenofovir, that's why it's an NT. What is that? Then okay, go through your pharma book again. Not answering this time. Then coming to the NNRTRI, that is efavirenz or etravirine, the newest drug. Protease inhibitor, ritonavir, and integrase inhibitor, dolutegravir. Only this, remember these examples because these combination of these drugs are used in the first line of ARTs now. Okay. And this is actually provided by our government. So this is this example will come to your exam, the chances are high. Okay, not the other things, because there are too much drugs. I have only given some names. What are the regimen? That is NTRTI, NRTI and integrase inhibitor, or 2 NRTI plus 1 protease inhibitor. And for pregnancy, 2 NRTI plus 1 NNRTI. What are the preferred first line regimen and alternative first line regimen? This table actually taken from your Park book. Okay. What are the full form of TDF and this? TDF is tenofovir. TC, Lamivudine, which coming to the NRT. Then DTG, Dolutegravir. And this first line actually has been used. Okay. And coming to the prevention of post-exposure prophylaxis, what you should know by heart for your own sake. Okay. What is that? Consists of first aid care, and then counseling and risk assessment, which is not needed for you but needed for others. HIV testing, and in 2016 guideline, anti-retroviral PEP for non-occupational exposure to HIV recommend either raltegravir 400 twice daily or dolutegravir 50 mg daily in combination with TDF and emtricitabine. Okay. And what are the prophylaxis for HIV related infection? In our government setup, we only supply cotrimoxazole for all kind of opportunistic infection. But there are some specific prophylaxis that you should know about. First off, what is P. carini? What P stands for? Pneumocystis carini. Correct. Then MAC avium, Mycobacterium avium complex. Then prophylaxis against Mycobacterium tuberculosis, that is isoniazid 300 daily. Okay. Then Kaposi's sarcoma. Kaposi's sarcoma actually has been asked. CMV retinitis, ganciclovir, cryptococcal meningitis, fluconazole, and esophageal candidiasis, also fluconazole, and herpes. For herpes, we all know that is acyclovir. There are also in primary health care, what extra services we do, that is mother and child screening for both VDRL and HIV. Also, before taking the child, we give them family planning and education. This thing is actually called cross-cutting intervention, because family planning is also needed for your life, that in your conjugal life, family planning idea and family planning drugs are needed. And with that, we are also giving them awareness regarding the STIs and HIV. That is why it is called cross-cutting intervention. Okay. Now coming to the program, that is NACP, National AIDS Control Program. When it is first launched, I already told you, in 1984 to 1986, one prominent female scientist actually first identified HIV. Anybody searched internet? What is her name? Okay. So, in 1986, first case of HIV detected by National AIDS Committee established by Ministry of Health and Family Welfare. But before that, that female scientist actually identified HIV cases among commercial sex workers living in Chennai. Okay. And in 1992, NACP Phase V first is launched. And in 2021, NACP Phase V actually launched, which is running for the next 5 years. That means at the end of 2026, we can either expect one new NACP or it might continue, just as he continued here from 2012, it actually for 5 years, but in 2017 only one act actually came, that is the act is, I will deal later, that HIV Prevention Act, and we waited up to 2021. What is the reason? In 2019 it actually started, but COVID hit. Okay. In the total NACP background, we actually test and treat policy for HIV patient. It actually launched in 2017. Okay. And this, the HIV prevention and this thing, actually it was called NACP IV extension period when it was not launched. Okay. This is 4 is not needed for you, but it's still there. You can see in the PPT if you need. Now coming to the NACP V. What is the goal? What is the first our goal? That ending AIDS as a public threat by 2030. And then we have some specific goal which is detailed. That what is the, but where it is focused and what is the difference between NACP 4 and 5. These last 2 points. First is community engagement, which is enhanced in NACP 5, and the use of digital health technologies, which was not, before that we only held telehealth services regarding STIs and HIV. But now we are taking digital health technologies, which is nothing but your smartphone applications, and keeping a online database. Okay. So what are the goals in details? It might be an important question for your Viva, that reduce annual new HIV infection by 80%. What is the 80%? What is the baseline? That the prevalence, the years of 2010. What was the number of 2010? We will reduce by 80%. Also reduce the AIDS related mortalities by 80%. Total elimination of vertical transmission of HIV and syphilis promote universal access to quality STI and RTI services, and elimination of HIV AIDS related stigma and discrimination. From goal, we coming to the specific or strategic objectives. In NACP 4 you all, or previously in previous class also you all heard about 90-90-90. Now we are targeting 95, achieve that 95 who are living with HIV should know about their situation. That means 95% should be diagnosed. Then out of them 95% should be on either first line of ART or alternative ART. And out of those who are getting treatment, about 95% of them should reach viral suppression. Another, less than 10% who are PL-HIV, that means people living with HIV, should face HIV stigma or discrimination. For that HIV Prevention Act 2017 came. What are the third objectives? Scale up HIV prevention in high risk groups and general population, ensure universal access, which is the direct interpretation of the goal, and strengthen surveillance, research and innovation. Now Sentinel surveillance sites are also increased in the NACPs. Okay. What are the key intervention? Targeted intervention for high risk groups, that is FSWs, MSM, IDUs and TGs. Then promotion of condom, you already know that, male and female in a large scale needle syringe exchange, and OST, opioid substitution therapy, and PPTCT, that is prevention of parental transmission of parent to child transmission. Okay. These are the key intervention we introduced, and how we achieving that? These are the strategic intervention. You do not need to remember that, just go through it. This table actually taken from the latest edition of PAR. Okay. Nothing, whatever we discuss there, how we achieve it, it is actually written. Nothing else, nothing more. These only things you should know about NACP 5. Okay. What are the differences between NACP 4 and 5? What are the objectives, goals, objectives and strategic interventions. Okay. Nothing else will come in your exam or even in your MCQ exams. Now to one important short note might come, that is, what is ICTC? What is ICTC? Integrated Counseling and Testing Center. Okay. So these things actually launched in the NACP 1 or 2, but people usually do not think of as if you are going there, then you should have some problem. You must have some problem. So they are getting stigmatized and ostracized from the society. So that is why we first introduced, when ICTC it was less in number also, and what we did divided into two types. One is fixed alone, okay, fixed ICTC. The center is fixed in a facility, and then coming to the mobile ICTCs. Okay. What mobile ICTC constitute? Paramedical staffs, those who know how to take the blood and test. Okay. The mobile ICTC is usually first targeted the high risk areas. You all know, from high risk areas, those who are belonging to the high risk groups, they usually do not come to the general population. So we have to go to them. And what will be the team? An ambulance, 2 or 3 workers who can collect the blood, and 1 or 2 counselor and sisters, okay, to treat. to give them the medicine necessary for any opportunistic infection or provision of first line ART. But later the provision of first line ART actually withdrawn. They can give them general counseling and medication for opportunistic infection. Then coming to the fixed ICTCs. Okay, these also type of two. One is standalone ICTC. This is in these centers, these are separated from the main building, main hospital building, and it has their own staffs. Okay, the staffs are not affiliated with the hospital, and we have some ICTCs which is integrated to the facility. The workers of the facility will do their duty part time by time, and for doing their duty in the ICTC they will be trained. Okay, so where we employ fixed ICTC and where we establish standalone ICTC or where we introduce facility integrated, where people are less. That is why below the block level, whatever the health facility is there, whether it is PHC or sub-center, there is facility integrated ICTC. And from the block level to the up, there is usually standalone ICTCs. And what are the ICTCs are now termed as Suraksha. When in your, I think in next week you have classes on STDs also, the syndromic approach. Menon sir will take the class. In that class, you will get to know the term Suraksha. Okay. So what are the ICTC? We all know. What are the type? I told you just now. And what are their function? That early detection and opportunistic screening of HIV and STIs. What is opportunistic screening means? In NPNCD, I also told that term. Opportunistic screening. What is opportunistic screening? Huh? Correct. If the person is coming for some another disease, but if the criteria fits, we will screen them. In NPNCD, if a 30 years old human being come, we will test them for and diabetes. Okay, for hypertension, we will check his BP, check his or her BP, and we will test them for diabetes and also lipid profile. What are the other functions? Provision of basic information, that is modes of transmission and prevention. We can use leaflet or chart also for that to give the information freely. Or we can, if one seeks out counselor, a counselor should be appointed there. Okay. Also promoting behavioral change. If we identify anyone that he is having some risk behavior, we can counsel. Also that is why results and counseling are purely confidential in the ICTC. They have their own database and the data will be uploaded in a secured server. So the data is not public. Okay. Reduction of fear and stigma and link with other HIV care, prevention and treatment service. ART center. Right now we also have some ART center where only anti-retroviral therapy is given. And also ART center we use the data for research purpose also. Or it's a HIV Sentinel site, Sentinel surveillance site, where HIV detection has been done, but and also ART provision is also there. ICTC will link up with those ART centers. And also creating enabling environment and emotional support. These are the founding principle and also the functions. Okay. This is an organogram. In the state and district level, we have standalone ICTCs. In sub-district, that civil hospital, community health center, standalone ICTCs and facility ICTCs depending upon the population. and this population, not the general population, depending upon the presence of HRG pockets and risk behavior people. Okay. In the village level, we might have some standalone and facility based, but at the community level, we usually use mobile ICTCs. Okay. Now coming to the next thing, that is HIV and AIDS Prevention Act 2017. Just remember only one thing, it might ask in your Viva that this law prevents to discriminate HIV patients in these 6 sites. Remember only these 6 sites, okay, sites. This might come as an MCQ, okay. It has been asked before in mock papers, but it might come as MCQ in your upcoming MCQ exams, okay. What are the 6 places? One is employment, second is education and establishment, third is healthcare service. That means these are the where this is the sites where we actually giving them service or getting their employment. So we cannot discriminate any person regarding their HIV status in their employment area. We cannot deny them their education because that is their right, and healthcare, that is also their natural right. We cannot deny them renting our own house. We cannot limit their entry to the any government or private offices due to their HIV status, and we cannot exclude them from getting health insurance because of their HIV status. But what will be the interest rate, that is not decided. Okay. Now government also start one adolescence education program. It is actually associated with school health programs also. Okay. That here usually counseling and general information has been given to the students. Red Ribbon Club. The purpose of Red Ribbon Club is formation in colleges to encourage peer-to-peer messaging on HIV prevention and provide a safe space for young people to seek clarification on their doubts and myths surrounding HIV/AIDS. In general colleges, usually in a block, if there are 5 or 6 colleges, they unanimously form a Red Ribbon Club. This is a mandatory UGC guideline also now. Okay. So they have to form, and in there they also might also create a helpline where one expert will answer all the answers regarding their whatever their question, okay, all their questions, and their name and year and education, everything will be confidential. Then coming to the next important, surveillance. What is surveillance, sir? What is surveillance? Continuous monitoring with impact and feedback and action. Correct. And how many types of surveillance actually we have for HIV? 6 types. Okay. Among them, HIV Sentinel surveillance is the prominent one, and it might come as a short note. What are the 6 types? That is, first is HIV Sentinel surveillance, then HIV sero surveillance, third AIDS case surveillance, fourth STD surveillance, fifth is I think behavioral change surveillance, and sixth one integration with other surveillance. Okay. So there are actually 5 types of AIDS surveillance in our country. What are the objectives of any sentinel surveillance? That to determine the level of HIV infection. Second, to understand the trends of HIV epidemic. Third, to understand the geographical spread of HIV infection. Fourth, to provide information for prioritization of program resources, whom to give much more resources. That means we have to identify where the high risk group pockets are situated and maximum amount or maximum proportion of the resources should go to them. Okay. 5, to estimate the HIV prevalence and HIV burden. Then 1 and 5 is same, sir. Objective 1 and objective 5 is same. Is it same or not? হ্যাঁ, কে একটা বলল? প্রথমেরটা কি বলেছে? প্রথমেরটা ইনসিডেন্স, দ্যাট মিনস HIV infection, how many new cases. And last is the to estimate the HIV prevalence. Prevalence is the disease burden. That means old case and new case. So, what are the study we do for HIV sentinel surveillance? That is annualized cross-section study. Okay. Only the cross-section study, this word you should remember. For sentinel surveillance, we do a cross-sectional study. But in cross-sectional study also, we usually take samples from 3 types of population. That is, one HRG group, one population cluster is breach population, and third is general population. And what is the number? That we come to it later. Okay. Right now, what are the number of HIV sentinel surveillance sites? That is 180. But we might never know what are the sites. Where are the sites are? Okay, because these are anonymous. You probably go to that site for testing of some other thing, that okay, probably I have diabetes, so let me check my MBBS. But what the blood they will take, they will also use it for your HIV testing. Okay. But what is the problem? When they send it for HIV testing, they will not write down your name. They are not in the business of informing you. They are simply doing the prevalence or infection part. Okay. So they will not inform you whether you are HIV positive or not. Okay. And for general population, usually we do not take any general people. What we take them? Pregnant women coming to facilities. Okay. So we can test both the babies, whether the baby might get HIV or not, and the mother. এক ঢিলে দুই পাখি মারছে, টেস্টিংটাও হয়ে যাচ্ছে, কাজও হয়ে যাচ্ছে. So what are the duration and sentinel surveillance round 2016 and 17? It is actually taking high risk group from IDU, intravenous drug user, MSM, men having sex with men, FSW, female sex worker, and TG, transgenders. For breach population, we take SMM and LDT. SMM is migrant workers and LDT long distance truckers, the most well known breach population. Okay. And for general population, pregnant women attending ANC clinics. So your next ANC clinic might be a HIV sentinel surveillance, but they will not disclose their status to you. What is the sample size? For high risk group, we have taken 250. For breach population, we have taken 250, and for general population, we have taken 400. What are the duration? 3 months for all of them. And what is the frequency? Once in 2 years for all of them. What is the specimen? Here dried blood spot. That dried blood spot is actually specific for IDU people. Okay. For breach population, serum at STD or TI sites. For pregnant women, serum only. Then testing protocol, to test protocol for everyone. Okay. So what is the why there are difference in numbers, sir? You all actually studied research methodology in the second year. Any idea why 250 for them and 400 for general people? Why the sample size is difference? Is there any reason or just কি রিজনে এটা করা হয়েছে? রিসার্চ মেথোডোলজি পড়ানো হয়েছে দেখলাম তো সেকেন্ড ইয়ারে, পিকো ইয়ে সবই তো পড়ানো হয়েছে। হোয়াট আর দ্য রিজন? রিজনটা যদি খুঁজে লিখতে পারো কিছু পরীক্ষায় এক্সট্রা নাম্বার পাবে। হোয়াট এভার। Okay, these are the only important things in HIV, but there are some more. You all should read the PPTCT and how it is when doing, which syrup is given to the child of a HIV affected mother. Which syrup? Obviously that will be a syrup because a baby cannot chew the tablet. What is the medication name? Huh? No. Nevirapine. Okay. What is the answer of the first? Which of the following age group accounts for nearly 50% of new HIV infection in India? C. Follow, sir. C. Acha. Second, which of the following statements about the National AIDS Control Program is correct? Might be a multiple option, okay? So please read the options carefully. Sentinel surveillance under National AIDS Control Program is used primarily all of the following except which of these is not a component of National AIDS Control Program or HIV strategic intervention in India? Which statutory act in India provides protection to person? Eta at least bole dao. হ্যাঁ এটা বি, এটা একটু আগেই বলেছি। সো আউট অফ 5 লাস্ট দুটো হচ্ছে গিয়ে ঠিকঠাক আমি উত্তর পেয়েছি। ঠিক আছে, দিস ওয়ান ফার্স্ট অ্যান্সার ইজ বি। ওকে, তো বইটা খুললে উত্তরটা পাওয়া যেত, গিয়ে পড়ো না, এটা সমস্যা আমাদের। হুইচ অফ দ্য ফলোয়িং, এটা এগেন এ আর ডি কে বললো, এ আর ডি কোনো প্রোগ্রামে প্রাইভেট হসপিটালকে ডাইরেক্ট হচ্ছে টাকা দিচ্ছে? কোনো প্রোগ্রামে, এনি প্রোগ্রাম হ্যাভ ইউ হার্ড যে এখানে প্রাইভেট হসপিটালকে সরকার বলছে নাও টাকা নিয়ে যাও? না, একটা প্রোগ্রামের ক্ষেত্রে সরকার মানে প্রাইভেটগুলো টাকা পায় টিভিতে। হ্যাঁ, সো এ তো নয়, ডিও নয়, এখানেও অ্যাকচুয়ালি single option was correct, again B. This one, every first 3 was correct, wrong was D. আর 3টে সাইট তো দেখলে কোথাও হসপিটালের নাম লেখা ছিল? এএনসি ক্লিনিক মানে কি হসপিটালস হয়? বোঝা গেল, 5-এ 2 গোটা ব্যাচ, যেখানে 5-এ 5 অ্যাটলিস্ট 4 ওয়াজ এক্সপেক্টেড।